Hey guys, my name's Christina, and this video is on hyperammonemia. Imagine you're on your family medicine rotation. You are chart checking a patient who just checked in, looking at the chief complaint, recent visits, lab work, and medication list. You notice a patient is on lactulose, and you quickly recall from your pharmacology lecture that this is used to decrease ammonia levels. How exactly does this medication work? And what would happen if the patient stopped taking this medication? You're going to learn all about hyperammonemia. After the next few slides, you should be able to 1. Understand how ammonia levels become elevated, 2. Describe the clinical signs and symptoms of hyperammonemia, and 3. Describe the various treatment options. Alright, so what is ammonia? Ammonia is a nitrogenous compound composed of nitrogen and hydrogen. Ammonia itself is toxic to our body, especially to our brain, and needs to be converted to urea, a non-toxic substance that can be excreted renally from our body. Ammonia is synthesized by amino acid metabolism and converted into urea through the urea cycle. While we won't go over the urea cycle in detail, I do think it's important to understand this picture here. Ammonia is synthesized by amino acids through muscle breakdown. It is then converted to glutamate, which is then converted to alanine, and alanine serves as a shuttle and can be transported from the muscles to the liver, where it can then be converted back to glutamate. This glutamate can now be used in the urea cycle, and will eventually form urea. Urea can now be excreted renally through our urine. This concept was always a little tricky for me to understand, but I think truly understanding the alanine and glutamate relationship within the muscle and liver helps. For more detailed information, check out our great video on the urea and alanine cycles. Okay, so how do ammonia levels become elevated? Well, as we just went over, the liver is a site where ammonia is broken down and put through the urea cycle to form urea. So any dysfunction in this cycle would cause hyperammonemia. This is typically seen in very advanced liver disease or hereditary urea cycle enzyme deficiencies. Excess levels of ammonia will be converted to alpha-ketoglutarate to form glutamate. This depletes the supply of alpha-ketoglutarate. When alpha-ketoglutarate supply is depleted, which important metabolic cycle is inhibited? Hopefully, you think of the TCA cycle. High levels of alpha-ketoglutarate also depletes glutamate and GABA stores in the central nervous system, which contribute to the encephalopathy symptoms patients may have. Elevated ammonia levels can cause flapping tremors, also known as asterexis, slurring of speech, somnolence, vomiting, cerebral edema, and blurring of vision. Can you recall the most common urea cycle disorder? Yes, ornithine transcarbamylase deficiency. The enzyme ornithine transcarbamylase catalyzes an essential reaction early on in the urea cycle. If this enzyme is deficient, our body cannot produce urea, and a buildup of ammonia occurs. This usually presents in the newborn stage of life with symptoms of hyperammonemia, including poor feeding, seizures, somnolence, abnormal movements, and encephalopathy. Lab findings also reveal elevated orotic acid in blood and urine. A deficiency in any other enzyme used in the urea cycle can also lead to hyperammonemia, though ornithine transcarbamylase deficiency is the most high yield. Organic acidemias, such as propionic acidemia and methylmalonic acidemia, can also cause high ammonia levels. Check out our videos on organic acidemias for more information. So how do you treat hyperammonemia? The mainstay in treatment is to limit protein in the diet, but there are a few different ways you can lower ammonia levels within the body. Recall lactulose, the drug we were introduced to in the beginning of this video. Lactulose works to lower ammonia levels by acidifying the GI tract. When you give lactulose, the ammonia gets converted to ammonium, which cannot cross the gut epithelium and will then be released through bowel movements. Other options include giving antibiotics, such as rifaximin or neomycin. These work to kill bacteria in the gut that produce ammonia. The USMLE exam is a critical thinking exam, so in the spirit of critical thinking, would you guess that rifaximin is a well-absorbed or poorly absorbed antibiotic? As you can imagine, a well-absorbed antibiotic would enter the bloodstream and peripheral tissues rather quickly. And do we want this? No, we want the antibiotic to stay in the gut where it can kill ammonia-producing bacteria. Therefore, rifaximin is poorly absorbed. This is why you probably haven't heard, or you're probably not familiar with it being used for anything else. Amino acid binders, such as benzoate or phenylbutyrate, can react with glycine or glutamate to increase excretion of ammonia. Okay, let's do a quick flash quiz. What are some signs and symptoms of hyperammonemia? Elevated ammonia levels can cause asterexis, slurred speech, somnolence, vomiting, cerebral edema, and blurring of vision. These are very important to recognize and highly tested on exams. Alright, so the bottom line, ammonia is a toxic substance synthesized by amino acids through muscle breakdown. Liver disease, urea cycloenzyme deficiencies, and organic acidemias are prime causes of hyperammonemia. And lastly, there are many different pharmaceutical agents available to lower levels of ammonia, including lactulose, rifaximin or neomycin, and amino acid binders, benzoate or phenylbutyrate. Thanks for watching. If you enjoyed this video, don't forget to give it a thumbs up.